Dr. Jinal, you can switch on the video.
Yes, sir.
So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. Today we have with us Dr. Jinal Trivedi. She is a consultant pediatric gastroenterologist and hepatologist practicing in Vadodara. She has done her MD pediatrics and she got fellowship in gastroenterology, hepatology and nutrition from LTMC Sion, Mumbai. And she has also done her fellowship in advanced endoscopy. She has a very vast experience in pediatric GI endoscopy, and she is affiliated to all major institutes in and around Vadodara like KGP Children's Hospital, Parul, Tiraj, etc. And she is going to talk to us about neonatal cholestasis, a practical approach, a very important topic for all pediatricians. So over to you, Dr. Jinal. Welcome to Saturday Club of Baroda, and thank you for accepting our invitation. Over to you.
Thank you, sir. A very good morning to all of my seniors and colleagues. At the outset, I would like to thank Dr. Satish, sir, to give me this opportunity to present my knowledge over this platform. So now I'll just start sharing my screen and we'll start with the presentation.
You have about 40-45 minutes to talk, and we keep 10 minutes for discussion.
Sure, sir. Yes. I've shared my screen. I hope
Yes.
it is visible.
It's visible, yes.
Yeah. So let's start with the presentation. I think the slides are not moving now.
No matter, no problem. You can try again.
Just stop sharing and start again. Share. Yeah, moving now.
Okay.
Yeah, so neonatal cholestasis will see a practical algorithm. Why I've chosen this topic is that, again, as Sir said, it's a very important topic for pediatricians, no doubt. But of course, it involves involvement from all other specialties also, including surgeons, radiologists, and all. So it's a topic of interest for a lot of specialties. So I thought let's talk about this topic today. A brief overview about what we will be talking is some theoretical part about etiologies and what is neonatal cholestasis and all of that. A basic approach, a practical approach, and then we'll be talking about a few cases of neonatal cholestasis. So starting with why neonatal cholestasis matters, it's a very important topic for us pediatricians because it has a high incidence rate of around 1 in 2,500 live births. And of course, it is 100% always pathologic. So whenever there is cholestasis, we need to evaluate the child. Why do we talk so much about cholestasis is because the most common cause of neonatal cholestasis is biliary atresia, which is a surgical emergency. So basically, we have a critical time window of first 60 days of life, wherein the surgical intervention is very critical for biliary atresia. So again, it is very important. If we look at the Indian scenario, neonatal cholestasis constitutes of around 90 to 33% of all chronic liver disease, which is a huge number in pediatric population. The most common causes being the hepatocellular causes around 45 to 69% and obstructive causes, that is biliary atresia, choledochal so 19 to 55% of those obstructive causes. So all of this constitutes a large importance of neonatal cholestasis in pediatric population. So how do we define that? First is a basic serum direct or conjugated bilirubin concentration should be done. If it is more than 1 gram per deciliter, if the total serum bilirubin is less than 5 mg per deciliter, or more than 20% of total serum bilirubin, if the total serum bilirubin is more than 5, then we consider this as a direct or conjugated bilirubin concentration. So whenever there is a conjugated hyperbilirubinemia, it is always pathological. It requires evaluation. So this is a basic definition. Now, when to evaluate? Any formula-fed infant noted to be jaundiced after 2 weeks of age should be evaluated for cholestasis, and breastfed baby should be given a time frame of 1 more week, that is 3 weeks of age, because the maternal milk contains beta glucuronidase enzyme, which generally converts the conjugated bilirubin to unconjugated at times. So we can give a 1 week buffer time to breastfed babies who is generally normal, otherwise no symptoms, growing well like that. So this is how, when we start evaluating or start thinking of neonatal cholestasis around this age. Etiology wise, this is a paper from Indian Pediatrics showing the etiology of neonatal cholestasis syndromes. Most common being the biliary atresia, then choledochal cyst, then comes our infections, metabolics, all miscellaneous unknown etiologies. Though there are a lot of research going on neonatal cholestasis syndrome, a huge chunk is the obstructive causes, that is biliary atresia, choledochal cyst, infections or metabolic conditions like that. But a still large number of percentage of population of patients, that is around 9 to 10%, are unknown etiologies or undifferentiated etiologies like that. So we still need to know a lot of causes of neonatal cholestasis. So just going through some etiologies in, no, of course, not in details, but some etiologies. One is hepatocellular causes, most common being metabolic and infections. In infections, sepsis is very common, UTI is common, torch infections are common. Viruses, all herpes virus, adenovirus, CMV virus, all the new Zika viruses and all can also cause neonatal cholestasis. In metabolic causes, the most common is galactosemia, tyrosinemia. Of course, other causes such as neonatal hemochromatosis, storage disorders, all are fatty acid oxidation disorders, peroxisomal disorders, all of those. Then the second part is paucity of intrahepatic bile ducts. That is, as the name suggests, paucity, that is reduced number or absent small bile ducts in the liver. This also causes neonatal cholestasis. Two types, one is syndromic, second is non-syndromic. So syndromic, most common is the Alagille syndrome. I think we must, most of us must be knowing about Alagille syndrome. Non-syndromic causes includes alpha-1 antitrypsin deficiency, all the familial causes of intrahepatic cholestasis, the PFICs, progressive familial intrahepatic cholestasis, sometimes viral causes, and idiopathic, of course. So let's go to Alagille syndrome. It involves a lot of systems, the cardiac system being the most commonly involved, around 85 to 95%. Sometimes it presents as peripheral pulmonary stenosis, sometimes with TOF, sometimes with ASD, VSD, all of those defects. The dysmorphic faces are present in 75 to 95%, being the dysmorphism being most commonly the prominent forehead, deep-seated eyes, triangular face, and all of that. If we do a liver biopsy, it will mostly show a cholestasis with paucity of intrahepatic duct in 90 to 95%. Skeletal abnormality is the most common. If we take an X-ray of vertebrae, there will be a butterfly vertebrae shape. Ophthalmologic is around, present in around 60 to 88%. That is, posterior embryotoxon is most common. So generally, it's a white line point at which the corneal endothelium and the trabecular meshwork join. Uveal trabecular meshwork join. Others are growth failure, neurologic, renal. So renal generally presents as renal dysplasias or sometimes ureteric reflux or all of that. Pancreas might also be affected. So in and all, Alagille syndrome affects almost all of the systems. So clinical presentation, there are two phenotypes. One is syndromic or embryonic, constitutes around 10 to 20%, has almost all anomalies considering other systems. Second is the perinatal or acquired, constitutes about 80 to 90% of the disease. Third and most common in our topic of interest is the obstructive cause, that is biliary atresia. It is around 40 to 45%. It constitutes of the whole neonatal cholestasis syndrome. So most important cause. Again, it can be non-syndromic and syndromic. Syndromic biliary atresia is generally present with cardiac defects such as ASD, VSD, or sometimes asplenia or polysplenia like that. So non-syndromic biliary atresia is more common than syndromic, generally presents with jaundice, acolic stool, and otherwise healthy growing child. So biliary atresia to diagnose as such is not difficult, but to counsel the parents that the child has biliary atresia, it is a surgical emergency, and the complications, that is a difficult task, because the child is growing well. Parents will come to you with just jaundice, and sometimes they don't even notice the jaundice, or sometimes they don't even notice the acholic stool or dark colored urine is a problem to them. They don't even feel that's a problem to them. So when you explain the whole, a lot of time it has happened with me that when I was explaining a lot the details, the anatomy, that there is a block here and your child needs a surgery immediately and all, and they were all in shock that what are you just explaining us? Our child is healthy, growing, gaining weight. There are no other symptoms and all. So yeah, it's a task to counsel the parents for surgical emergency and all for biliary atresia. So now, we have looked for the etiologies, the basic etiologies of neonatal cholestasis. Now we move forward with the approach. So approach is basically, first of all, identify cholestasis, as we saw from the definition of to how to identify cholestasis. And second and most important is rule out biliary atresia. Once, and again, I'm highlighting this because it's a surgical emergency, is the only cause that's an emergency cause for treatment of neonatal cholestasis. Rest others we can just wait and watch or keep doing investigations and then make a diagnosis. Third part we will talk about in details about later. So basically 3 points: history, physical examination, investigations, as we do in every approach kind of thing. So first, so basically this is a very common question that has been asked, that can I know without blood test whether it is unconjugated or conjugated? So the answer is yes. Whenever the child presents with jaundice plus dark urine, so dark urine has to be there to define it as a conjugated hyperbilirubinemia. Clay colored stools may or may not be present. So if these symptoms are present, then yes, we can say that without blood test that this is a conjugated kind of hyperbilirubinemia. History-wise, all family, prenatal history, consanguinity, neonatal cholestasis in the siblings, history of repeated fetal loss or early demise. All of this gives a clue to the genetic, sometimes metabolic conditions, sometimes familial conditions of neonatal cholestasis. This table shows some maternal history diseases to consider. I don't think we need to go into details of all of this. Sometimes maternal infection during pregnancy gives a clue to the congenital infections, as the torch infections and all of those. Postnatal history becomes very important, whether the child was preterm or term, because there are high chances of sepsis in preterm babies. In term babies growing well, again, biliary atresia. Birth weight, again, is important. Growth failure is important because biliary atresia, choledochal cyst, all those causes where the child is not sick or growing well. So basically, those causes are different. When growth failure occurs, the causes are different, like metabolic conditions, all are infective conditions. All of those will lead to growth failure. Then, of course, birth defects, anomalies, visual defects, auditory, all of the syndromic kind of presentations of neonatal cholestasis. If there is hypoglycemia, seizures, vomiting, irritability, lethargy, hypotonia, all of this point towards the metabolic conditions like galactosemia, tyrosinemia, or other sick causes such as fatty acid oxidation defects or our peroxisomal disorders. Then comes bleeding manifestation. So bleeding manifestation is generally a sign of advanced liver disease. Sometimes it happens in biliary atresia also when there is an advanced liver disease. A lot of time it has happened that the child presents at 8 months or 9 months of age with symptoms of decompensation of liver disease. The parents did not notice jaundice because it was intermittent jaundice. Pale stools was also intermittent, so they did not notice, and has now come with signs of advanced liver disease. So mostly bleeding manifestation is a sign of advanced liver disease, or sometimes gestational alloimmune disorders. And again, in history, stool color, asking for stool color is important. I'm highlighting that because that's the most common, most important thing to ask in history, stool color. So always ask the stool color to the parents. Then comes examination, a thorough examination. Again, what all we have asked in history, we need to examine. The growth needs to be examined. Any dysmorphic features needs to be examined. Anomalies need to be examined. If there is murmur, if there is palpable mass, all of that. Hepatosplenomegaly for storage disorders or other diseases. Eyes again for cataracts. Posterior embryatoxon for Alagillase. CVS for peripheral stenosis, TOF, ASD, VSD, all of those. Neurological development for developmental delay, and signs of decompensation. That also we need to examine. Again, in examination, the most important part is stool color. So it just asking the parents that what is the color of the stool does not give us clue, because most of the time the parents do not notice that this is an abnormal color of the stool because it keeps on changing. Sometimes even in biliary atresia, there is intermittent pigmented stool. So they do not get to notice. So stool color is very important, and examining yourself is very important. So what I generally do is so basically we show the stool card to the parents and ask them that what color does your child is passing stool like. And generally the above three are the abnormal stool colors, that is ecolic stool. The below three are the normal stool colors. And then what I generally do is I ask them to send pictures of the baby stool for consecutively 3 days, because we need to serially assess the stool color. So that's important. This is some table. What we have talked is the same thing, pointers towards a clinical diagnosis of all the diseases. I don't think we need to go into this. Yeah, so now this is an important slide. Like clinically, how can you differentiate between biliary atresia versus neonatal hepatitis? So biliary atresia, generally there won't be any dysmorphic faces in biliary atresia, whereas neonatal hepatitis might have dysmorphic faces. If splenomegaly, again biliary, we can think of biliary atresia, or sometimes metabolic conditions. Ascites is there, then we can think of decompensation, liver failure, which is more common in neonatal hepatitis than biliary atresia, because in biliary atresia, decompensation occurs later in life. Again, all other eye examination, other systemic involvements will point towards the neonatal hepatitis less than biliary atresia. So clinically, these pointers differentiates between biliary atresia and neonatal hepatitis. So investigation-wise, history examination is done. Third part is investigation. So investigation, we will order a complete hemogram, liver function test with gamma glutamyl transferase, PTINR, APTT, thyroid profile, and urine routine. So these are the basic tests that we order first. And the second part is the ultrasound abdomen. Now, this is a very important test investigation that helps us diagnose biliary atresia. So generally, ultrasound abdomen we do in both fasting and postprandial stages. Fasting is generally for 3 to 4 hours, and we look for we look for other that we will discuss further in further slides. So what's the role of GGT? Of course, GGT is very important because it's a marker of cholestasis. So generally cholestasis mostly there will be elevated GGT. Most of the causes will most of the syndromes will show us elevated GGT, most important cause being biliary atresia, bile duct paucity, sclerosing cholangitis, and there are a very few causes of low GGT. So whenever there is low or normal GGT, we will always think of bile transport defects or bile acid synthetic defects, or our PFICs, that is progressive familial intrahepatic cholestasis. Now, even in PFICs, we till now knew only 7 types. A lot of researches are going so now ongoing. So now we now know around 11 types of PFICs. Not all PFICs presents with low or normal GGT. Most of them, like 1, 2, 4, 6, all of them presents with low or normal GGT. So only 2, 3 causes of low normal GGT. Otherwise, or everything else will present with elevated. So yes, GGT is important with LFT for neonatal cholestasis. Now, these questions are very frequently asked. That does liver enzymes helps to distinguish the underlying cause of cholestasis, and is GGT useful? I think for GGT we've already discussed. To answer that liver enzymes, the first question, no, liver enzymes as such do not help differentiate underlying cause, because they do not generally give us an idea of what is the underlying pathology that is going on. But whenever there is SGOT, that is AST more than ALT, so generally we see that in advanced liver disease, or whenever there is muscle involvement, because definitely SGOT is present in muscles and all like that. So yeah, as per se, SGOT, SGPT do not help us differentiate underlying cause, but they do give us some idea. What does deranged INR signify? So whenever a lot of times it has happened that a biliary atresia child has come to me with deranged INR. So what do? We just give first dose of vitamin K at 1 mg per kg, repeat after 6 to 8 hours. So usually in biliary atresia, it is correctable with vitamin K, unless the child has presented in decompensated phase or in cirrhotic phase. But even after vitamin K, if it is uncorrectable, so uncorrectable coagulopathy is a clue towards metabolic conditions or other causes of neonatal hepatitis, or other causes like fatty acid oxidation defects, paroxysmal disorders, all of those sick child causes. So basically, yes, INR also gives us a clue that ways. Now talking about again coming to our main topic of interest, the biliary atresia. This slide we have already spoken about. So acholic stool. Now we always say that whenever there is clay colored stool, it is just biliary atresia, but it is not so. Clay colored stool is not just biliary atresia. It is of course suggestive but not diagnostic, because a lot of other causes like presence with acholic stool, like the acholic stool is also seen in severe intrahepatic cholestasis. So other causes biliary atresia mimics that we call of, that is our PFICs, all our paucity of bile duct causes, all our neonatal hepatitis, sometimes torch infection, sometimes storage disorders, all of those also have acholic stool. So no, acholic stool does not always mean biliary atresia. Of course, and even in early course of biliary atresia, the stool may appear normal or intermittently pigmented. So that is why we need a serial assessment of stool colors. So yeah, these are the pictures of acholic stool from all of the patients that I've been seeing of biliary atresia. Ultrasound abdomen, yeah. So why this investigation is very important, because generally we need a fasting stage of 3 to 4 hours. What do we look for biliary atresia is, first of all, is liver, of course, the echo texture and the size and all of that in liver. In spleen, we look for any splenomegaly, polysplenia, spleniculi, that is the syndromic features of biliary atresia. Is there any presentation of ascites or like decompensation of liver disease? So basically in gallbladder, the gallbladder is the most important part to see in diagnosis of biliary atresia on ultrasound. Either the gallbladder is absent, contracted, or rudimentary. We can also see a cyst at quota, triangular cord sign. So basically triangular cord sign is a thick fibrotic, we will see in pictures in the later slide, but it is a thick fibrotic remnant of obliterated bile duct. That's called a triangular cord sign. Of course, other findings such as choledochal cyst, biliary sludge, choledocholithiasis, all of that. So this is a USG showing a contracted or atretic gallbladder that has been labeled, and this is an enlarged hepatic artery. This is a basic pre-fasting, this is a fasting stage of USG for biliary atresia. Here we can see a triangular cord sign, the thick fibrotic remnant of obliterated bile duct, the arrow that shows the white colored thing. This is a triangular cord sign, and it is diagnostic of biliary atresia. Then comes, after USG comes the HIDA scan. Now HIDA scan is very controversial, that not a lot of people recommend it. So basically now ISPGHAN, that is the Indian Society of Pediatric Gastroenterology, the European Society, the North American Society. So basically they do not recommend doing HIDA scans now, because the specificity is low and we do not get results that we need. So there are two pictures of HIDA scan here, A and B. So B scan is a normal scan, that is basically the radioactive tracer uptake is seen in the small intestine after in the period of around 4 to 24 hours after the test. So that's a normal excretory scan. Whereas in the A scan, even after 24 hours, we are not able to appreciate the tracer in the small intestine. So that scan is called a non-excretory scan. So basically, HIDA tells us that whether it is an excretory or non-excretory scan. However, it does not diagnose biliary atresia, because a lot of conditions may present with non-excretory condition. So yeah, HIDA shows non-visualization of the radioisotope in the small intestine, as I said, suggests either bile duct obstruction or severe inability of the hepatocyte to secrete. Also, to do HIDA scan, we need to prime with phenobarbital for at least 3 to 5 days, because so phenobarbital, what does it do? It is a cholinergic agent, so it induces liver enzyme, enhances bile flow, and helps in uptake of the radioactive tracer. So generally, we need to prime the child for 5 days at a dose of 5 mg per kg in divided doses, and then do this HIDA scan. So it generally takes 6 to 7 days, 5 days of priming, then the day of scan, and then we have to wait for 24 hours for the to see whether the radioactive tracer is being excreted or not. So 7 days, and we get no specific report out of it. However, the negative predictive value of this scan is very high, almost around 90 to 99%. And whether if it is excretory, then the obstructive cause is definitely ruled out. So we have done ultrasound, HIDA. Now what to do? The third and the most important investigation is liver biopsy, and it is the definitive investigation. So how does liver biopsy help? Is first of all, it helps in the diagnosis of biliary atresia. If not biliary atresia, then helps in the diagnosis of other causes also, such as Alagille, neonatal sclerosing cholangitis, or some other metabolic liver diseases, viral infections, all of those. So liver biopsy is a better investigation. Also, it helps to prognosticate, as it can grade and stage the liver disease, whether it is an advanced, has gone to fibrosis or cirrhosis, or all of that. So when a child with neonatal cholestasis, we prefer doing HIDA. If it's excretory, then EHBA is ruled out, and we have to look for other tests. If it's non-excretory, may or may not be EHBA. So that's what the specificity is low for HIDA scan. So then we need to proceed to liver biopsy. So what we generally do, again, it needs 5 to 7 days of priming. So what we generally do is, if a child with neonatal cholestasis, we are suspecting biliary atresia, or we are not sure that whether it can be neonatal hepatitis or biliary atresia, we generally prefer doing a liver biopsy earlier and skip HIDA scan. So that gives us why? Because the report comes same or next day, so it's easy. We get the report earlier, diagnosis is made early. If it is biliary atresia, child gets operated early, prognosis is good. So neonatal cholestasis, liver biopsy is the investigation of choice. Now, this is a liver biopsy image of biliary atresia. Here we can see a lot of portal inflammation, bile ductular proliferation, a lot of fibrosis. So this is typical of biliary atresia. Now, gold standard. Now, all of this is done. The three things is done. USG is done, HIDA is done, liver biopsy is done. But there is one more investigation which is now considered as gold standard for biliary atresia, that is peroperative cholangiogram, intraoperative cholangiogram. So what do? Is we place a catheter in the cystic duct, and then pass dye from it, and then see whether the blockage is there or not. These images are from peroperative cholangiogram. If there is blockage, then and there we can treat, like do a Kasai photoenterostomy and do the surgical operation. If it is not, then again, if this is an intraoperative cholangiogram, then we can even take a liver biopsy during that. So again, this is a gold standard peroperative cholangiogram. Treatment is Kasai photoenterostomy, that is connecting the liver to directly the small intestine, so that we bypass every biliary drainage and enhance the biliary drainage. So Kasai photoenterostomy is the treatment of choice for biliary atresia if the child presents to us before 90 days, before 60 days, but then we give a buffer of 30 more days, so 90 days of time. After Kasai photoenterostomy, so what do we expect after Kasai photoenterostomy? It depends on what age it has been done. So the best prognosis is when it is done in less than 30 days of age, gives us around 70 to 80% of biliary drainage. Between 30 to 60 days gives us 50 to 60%, and after 60 to 90 days gives us 40 to 50% biliary drainage. 90 to 120 days is 20 to 30%. We generally do not consider doing Kasai after 90 to 120 days, because biliary drainage is less, leads to a lot of complications, and then it's not useful. So yes, Kasai photoenterostomy is only useful for first 3 months of life. Now, if jaundice clears by 3 months after Kasai photoenterostomy, then a 10-year transplant-free survival, we can explain the parents, that will be around 75 to 90%. If the jaundice persists, that is more than 6 mg per deciliter, then a 3-year transplant-free survival is only 20%. So basically, when do we call that a Kasai photoenterostomy has failed? Failed Kasai is that when the bilirubin concentration is more than 3 mg per deciliter, even after 2 months of Kasai, doing Kasai procedure. So that is labeled as failed Kasai. Or if there are other symptoms of cholangitis, infections and all, that also comes under failed Kasai. So generally 50% will require a liver transplant in less than 2 years of age, and 75% will require a liver transplant in less than 20 years of age. So we have done two things. We have identified cholestasis, ruled out biliary atresia, spoke about biliary atresia. Now the third part is to rule out life-threatening metabolic or genetic disorders which are amenable to specific treatment. So let's talk about that. Now this is a approach based for diagnosing neonatal cholestasis. Now that it is the approach is based on two types. One is a non-sick baby, one is a sick baby. So non-sick baby will order the routine investigations. We'll see the stool color. If the stool is pigmented, then we'll go ahead with ultrasound. We'll do the GGT. If the GGT is raised, then work up for genetic metabolic disorders, genetic for our familial intrahepatic cholestasis and all of those, metabolic for galactosemia, tyrosonemia. If the GGT is normal or low, then again PFICs or bile acid synthetic disorders. So this is for pigmented stool. Then comes for the pale stool. So for pale stool, again biliary atresia, we need to rule out urgently. Fasting USG should be done. Two types of diagnosis. One is choledochal cyst, one is biliary atresia. So both of them will have surgical option as treatments. And also with choledochal cyst, we need to rule out cystic biliary atresia. So generally, we will talk about cystic biliary atresia when we see the cases. So this is an approach for a non-sick baby. This approach is for a sick baby. So whenever a sick baby comes to you with neonatal cholestasis, again we need to order the routine investigation, give it injection vitamin K, and first and foremost thing is to rule out sepsis. So sepsis is the most common cause of sick neonatal cholestasis. Rule out sepsis, treat sepsis. Even after treating sepsis, the cholestasis part is still there. Then we need to work up for galactosemia. However, if there is no sepsis, then we need to work up for metabolic disorders like other tyrosinemias, galactosemias. Sometimes, like there are different varied presentation of galactosemia. Sometimes it will present with sepsis. Sometimes it will present without sepsis. All other congenital infections will also come under sick presentations, that is HSV, CMV, all of those. So this is a basic approach of sick and non-sick child of neonatal cholestasis. This table shows a targeted evaluation as per the diseases. I don't think we need to go into details. Just two things: galactosemia, urine for non-glucose reducing substances, and GALT assay, because those are common. Tyrosinema, urine for your succinyl acetone. And for torch infections, we know we need to do PCRs, and for sepsis, CRP, blood urine, and all of those. Again, ophthalmologic examination, cardiac evaluation, genetic testing, all of those testing needs to be done. So genetic testing, there are three options available with us. One is next generation sequencing. That is, so basically it targets specific genetic panels when we are sure that maybe if I'm looking towards familial intrahepatic cholestasis and I'm sure that this is PFIC, then next generation sequencing might help me. The second and most frequently used is the whole exome sequencing that we all use for genetic testing. The third is the whole genome sequencing. So the whole genome sequencing, difference in exome and genome is genome gives a detailed report, sees everything in detail, but again cost wise it is more compared to the exome sequencing and takes a lot of time for the report. So we generally prefer whole exome sequences, gives us all our answers, so works with us for diagnosis of neonatal cholestasis. Torch, again for torch infections, CMV causes neonatal hepatitis, but it is self-resolving, need not treat unless there are deteriorating liver functions or other systems are involved, like ophthal is involved, there's chorioretinitis or cataracts or all of those. And HSV is there. Also, HSV infection has a rapid deterioration. So we generally need to see the torch panels for that. Yeah, so this is all about the theory part of neonatal cholestasis. Now we will move forward to cases. I think we have time for around 5-10 minutes. So there are three cases. We'll see how much we can discuss. So this is a case one of she's a 42 days female child, full term, appropriate for gestational age, 2.8 kg, normally vaginal delivered, first in birth order, non-consanguineous marriage, uneven full birth history, exclusively breastfed. So everything was okay, normal birth history, everything. Now this child presented at 4 weeks with yellowish discoloration of eyes, dark yellow urine, but the stools were yellow as per the mother. The mother said that stools were pigmented. At 4 weeks. Then at 6 weeks, this child presented with poor feeding, lethargy. The child was lethargic, wasn't taking feeds properly, had presented with abdominal distension. So all of this while at 4 weeks of age, when there was some yellowish discoloration and some dark yellow urine, they did consult, but they were not sure that whether this is something serious or not. Until the child developed poor feeding and lethargy at 6 weeks of age. That's when they came. But there was no history of fever, no bleeding, nothing. On clinical examination, the child was sick looking, lethargic. There were no dysmorphic faces. Weight was 3.1 kg, birth weight was 2.8. There was deep icterus, pallor was present, there was tachypnea, respiratory rate was 64 per minute. Child was maintaining SpO2 at room air, heart rate was around 130 CRT, 3 seconds. Her abdomen was distended, soft, liver was around 4 centimeters below right costal margin. The spleen was not palpable. There was fluid, there was ascites. Respiratory system was normal. CVS was no murmur. So this was the clinical examination of the child with this history. Now, based on the approach, what we will see that this is a sick child. Again, I'm just sharing the same approach slide. If this is a sick child, what we need to do is, first of all, we need to rule out sepsis. If not sepsis, then we need to rule out other causes such as metabolic congenital infections. So what we did is we ordered the routine investigations, and the routine investigations came to be this. The total bilirubin was 13 with a direct of 8.2. SGOT, SGPT were in 679 and 541, that is almost more than 20 times normal upper limit. GGT was raised at 167. PTINR was deranged 37, 3.5. RBS came out to be low, 39. HB was 8.5. Platelet count, there was thrombocytopenia 1 lakh. CRP was raised 90. So there is some sepsis along with hypoglycemia, coagulopathy, and some derangement of liver enzymes. So of course we did a USG abdomen because it is must. Biliary atresia should be ruled out in all cases. So liver enlarged 9 centimeters, but normal ecotexture, gallbladder normal. So once we read that gallbladder is normal, we generally think that biliary atresia is ruled out. Spleen is mildly enlarged, moderate ascites present. So all of this. Now with all of this, we went ahead. So basically, based on the approach, we thought of 3 differential diagnosis. That first and foremost is sepsis. Second is metabolic disorder. The clue was the hypoglycemia, was the clue to metabolic or congenital infections. So we have a 42 days old sick baby with neonatal cholestasis, with failure to thrive, with some ascites, coagulopathy. There was metabolic acidosis on investigation, hypoglycemia, some anemia, thrombocytopenia, all of this. So then what we did is, we treated the child for sepsis, gave IV antibiotics, post vitamin K, gave vitamin K. So post vitamin K also the PTINR was still deranged, 32 and 3. Hypoglycemia was corrected, but again with increased glucose infusion rate. But whenever it was tapered or stopped, it recurred. So then we sent the blood cultures. Blood culture showed Klebsiella infection. So basically this was sepsis definitely, but then something eye examination showed cataract. So once eye examination showed cataract, we sent a urine for non-glucose reducing substances, which came out to be positive. So here we were going towards our diagnosis that we ruled out sepsis, treated sepsis, yet the symptoms are present. So we were thinking about galactosemia, urine and GRS came to be positive. So we sent a GALT assay. GALT assay shifted the child to soy milk. That is, we do not want to give anything that contains lactose, considering galactosemia. However, this child took left against medical advice. They were not ready to stay. We sent this child on fat soluble vitamins and MCT oil. So now this child comes for follow up in OPD after 5 months. So luckily they left against medical advice, but did follow the medical advice that was given to them, was on soy milk at 5 months of age, came back, gained weight. The child has gained weight, LFT, INR, everything improved. There was no cataract. And then so after 5 months, we saw the report for GALT, and which was very low. So here the diagnosis came out to be galactosemia. The child is now around 11 12 months, gaining weight, doing well, still on soy milk, and all the parameters are in normal range. LFT is normal, everything is okay, no cataract. He's still on fat soluble vitamin supplementations and MCT oil. So yeah, this was a case of galactosemia. Moving forward to case 2. So this is a case of a 32 years female. The ANC scan was done at 35 weeks of gestation, which showed a cyst that it was around 1.5 into 1.2 into 1.5 centimeters, adjoining the inferior surface of right lobe of liver. The diagnosis was query-choledochal cyst was given on ANC scan. So the mother was counseled, advised to review after birth with pediatrician. Now post-birth was a full-term child, normally delivered, cried immediately, nothing significant, 3.4 kg. USG at birth was done, query-choledochal cyst was given. This child had jaundice at 5 days of life, was breastfed, gained weight, growing well, everything. This is a stool picture of this child, was passing ecolic stool, but growing well. Now, then this child came again after 1 month, he was 1 month old, came with persistent jaundice. Now we advised investigations. So on investigation, the total bilirubin came out to be 7.9 with a direct of 4.8. SGOT-PT is minimally deranged, 9658. ALP was very high. GGT was very high, 433. HB was 10.2, otherwise normal. So USG abdomen showed a cystic area seen at POTA. So looking at all of these things and the ANC scan, we thought we have a diagnosis that this is a choledochal cyst. We went ahead with MRCP as choledochal cyst needs a MRCP. But what happened on MRCP is we saw focal dilated cystic structure in the that was communicating with the gallbladder. But there was one more sign, that is the inverted triangular hyperintense structure seen at POTA. So that's when we at 52 days of life, that's when we thought this just does not look like just a choledochal cyst. We need to rule out something more. So we went ahead with a HIDA scan, came out to be non-excretory. Again, we did so then we thought of doing a POC. And this can be biliary atresia, did a POC at 60 days of life. POC came out to be non-excretory. This child got operated for portoenterostomy at 60th day of life. This child was a lucky child that 60th day of life is the critical time window, got operated, and then we put a diagnosis of cystic biliary atresia. So what happened in this child on ANC scan was it was a choledochal cyst, and all this was the intraoperative liver biopsy showing bridging fibrosis, bile duct proliferation, all of this. So basically this presented with antenatal USG of choledochal cyst, jaundice, again everything was matching choledochal cyst, but then the MRCP and HIDA gave us some information. So then this was a case of cystic biliary atresia. So cystic biliary atresia is generally a variant is seen in around only 5 to 10% cases of biliary atresia. What happens that there is so much of block that sometimes the blockage, the small ducts forms a cyst near the hilum of the liver, and then it looks like a cyst, like a choledochal cyst. So it's a close diagnosis of choledochal cyst, the cystic biliary atresia. Child got operated, Kasai portoenterostomy was done. The child is now around 1.5 years of age, doing well, growing well. Now we need to just monitor him for the symptoms of advanced chronic liver disease, and whenever this child will need a liver transplant if at all in future. Do we have time? Should I go ahead with the last case? I think, yeah, 5. It will just take 5.
Yes, please go ahead.
Yeah, so this is the last case. This is a 9 weeks male child, full term, appropriate for gestational age, normal vaginal, delivered, was a third born out of third degree consanguineous marriage, breastfed, accepting, feeds well, everything was normal. This child, a mother noticed yellowish discoloration of eyes at 4 weeks of age, presented with ecolic stools. Otherwise growing well, but there is no history of fever, no poor feeding, no lethargy, no excessive crying, no abnormal body movements, nothing. So what will we think? Again, non-sick child, ecolic stool. So we will go towards the approach of the non-sick, that we need to rule out biliary atresia first. If not biliary atresia, then everything else. Now then presented with progressively increasing jaundice, got evaluated at some local hospital, came out to be conjugated hyperbilirubinemia. These were the investigations. Total serum bilirubin was in the range of 30s with a direct of 17.5. But the catch is the OTPT was normal. The catch here is GGT came to be normal. So what we were thinking is that this is a biliary atresia kind of thing, but GGT came out to be normal. But on USG abdomen, again, the gallbladder is contracted. So to spiking things, we can see that the normal GGT, but the gallbladder is contracted. So again, we were confused what to do. Did a HIDA came out to be non-excretory? Again, we are confused that whether it is still extrahepatic biliary atresia at 6 weeks of age. Child went per operative cholangiogram. So per operative cholangiogram came out to be excretory. Now, once this is excretory, it was it was obvious that definitely this is not biliary atresia. We are dealing with something else. Then this time, so I saw this child at this point that with a per operative cholangiogram was normal with me. This was the clinical examination at 10 weeks of child. No dysmorphic features. There was deep icterus, pallor was present. All other systemic examination was normal. Growing well. Weight was 4.5 kgs. Per abdomen, mild distension. Liver was 2 centimeters. Soft. Right, no splenomegaly and no ascites. So this is the summary, 10 weeks old child, but the catch is that it was a third degree consanguineous marriage. Progressively increasing jaundice since 1 month of age with echoic stool with her normal GGT and normal POC. The bile acids came to be elevated. So we were thinking of something that this is some familial cause. So I was thinking that this is some familial intrahepatic cholestasis or a transport defect. Let's go ahead with liver biopsy. Liver biopsy was done. Biopsy showed marked canalicular cholestasis. The liver architecture, however, was maintained. There was no inflammation, no fibrosis. Bland cholestasis. So we went ahead with the diagnosis of progressive familial intrahepatic cholestasis. For that, we needed to send the genetic panel, like as in what kind of FIC is that. So genetic panel came out to be ATP8B1 gene mutation, that is FIC1 deficiency, also known as Bylard's disease. So PFIC1, the child was started with supportive treatment. As there is no definitive treatment for this disease, we just need to give supportive treatment, some nutritional support, UDCA. So basically PFIC child does present with a lot of pruritus. So you need to treat pruritus. UDCA was given for pruritus, fat soluble vitamin supplementation. Now at 8 months of age, this child came with intractable pruritus. So much so that we needed to do a biliary diversion. So biliary diversion was done at 8 months of age. Now what? So further, what will we do with this child? Will we recommend liver transplant to this child or not? So basically in PFIC1, we do not recommend liver transplantation. Why? Because this gene has extrahepatic expression also. So even after transplant, the symptoms will still be there. It won't give him, won't improve the quality of his life. So basically post-transplant also, there are a lot of problems like intractable diarrhea, recurrent pancreatitis, poor growth, and all of that. Does not improve the quality of life. So we generally do not recommend liver transplant. Just give supportive treatment in this child. Treat pruritus. That's it. So yeah, these were the 3 cases. So whenever a child with neonatal cholestasis presents, first and foremost, check the stool color. First line investigations, the routine CBC, LFT, GGT. USG should be done. Look for treatable causes and injection vitamin K. And yes, early referral should be done in cases of biliary atresia. A few slides about management. First is whether we have to see whether there is any specific medical therapies present or not. If not, only supportive care. Now, this is the specific disorders which are specific therapies like biliary atresia, choledical cyst, all of those surgical interventions. Infections, antivirals, antibiotics, of course, galactosemia, galactose-free diet, tyrosinemia, nitisinone, and low alanine diet, and all of this. So basically, these disorders have specific treatment. The others that do not have specific treatment, that we just need to give the supportive treatment. So this algorithm shows that what treatments need to be given at what stage. In the early diagnosis, early stages, we just give the disease specific therapy if it is available. If not, then supportive treatments. In chronic cholestatic phase, we need to supplement with fat soluble vitamins, MCT formula for growth, and all of that. And in stage when the liver disease has progressed to fibrosis or portal hypertension, of course, you have to monitor for portal hypertension, hepatocellular carcinoma, all of those. And at later stages, at end stage, we also need liver transplant evaluation, also neurodevelopmental and family support. Where there is no specific treatment, we just have to improve nutritional status through parenteral. Sometimes parenteral nutrition is also needed. Sometimes for fat malabsorption, MCT oils, fat soluble vitamin deficiency should be treated with all the fat-soluble vitamin supplementation, and then we need to do early diagnosis and management of complications. So for pruritus, again, all the treatments. For varices, we need to do upper GI endoscopies, keep grading the varices, start on propranolol for primary prophylaxis, do a ligation or sclerotherapy whenever needed. For ascites, sodium restriction, all of these are normal. For spontaneous bacterial peritonitis or cholangitis, also antibiotic time, screening for other complications, and liver transplantation. These are the doses for fat-soluble vitamins that we need, that we give in neonatal cholestasis. These are some other drugs that we use and dosages of that with mechanism of actions. I don't think we need to go in details. So yeah, so all in all, the highlights of neonatal cholestasis is consider it as an emergency because 1 in 3 cases are biliary atresia. Early referral is the key. Whenever there is a sick baby, rule out infection, sepsis, metabolic causes, all of those. Non-sick baby growing well, biliary atresia. 3 common tests: USG, abdomen, HIDA, liver biopsy. Fasting USG should be done. Non-excretory HIDA may or may not be biliary atresia. So if baby is more than 6 weeks, then we directly proceed to liver biopsy because we do not want to waste time for priming and then wait for 1 more day for the report. Kasai portoenterostomy is successful only when done before 90 days of age. Liver transplantation after failed Kasai portoenterostomy is offered whenever there is advanced liver disease of any etiology or advanced fibrosis. Then once biliary atresia and paucity are ruled out, we need to investigate for other, that is hepatocellular causes. And then supportive treatment is, of course, there: nutrition, fat-soluble vitamin supplementation, and management of complications. So yeah, this is the highlight of neonatal cholestasis. Yeah, I'm done. Thank you.
Thank you. You can stop the screen sharing now.
Yeah, I'll just stop sharing if there is any discussion.
Thank you, Dr. Jinal. It was very comprehensive. I would say one of the best I have heard on cholestasis because you have covered all the things in a very short period of time.
Yes.
And overall, overview was excellent. So
Thank
now
you,
the house is open for discussion. If there is any question. Because there is a heterogeneous non-pediatrician audience here and on the YouTube also. Can you please share some data about how the liver transplant in kids is progressing in our country in last decade? Because that will be of interest to all of them.
Yes, sir. So nowadays, yes, liver transplant is being now used in India, like has come to India now, where a lot of causes we now are able to diagnose and then refer for liver transplant. So generally, all those biliary atresias, which has advanced advanced liver disease, all of those other causes such as PFIC. So generally, we did not used to see PFICs a lot of time, but now PFICs we do refer for liver transplantations. And so now I would like to say that the success ratio for liver transplant in pediatric population is around 80 to 85%. It's a good number as compared to adult population. Considering pediatric population and their own complications, managing complications and all, it's a good number. Also, a lot of knowledge has been given to all the pediatricians and all other heterogeneous populations. Also, a lot of people know that when to refer for liver transplantation and like that. So in and all, yes, it's a improving side in our
Can you name few centers where it is routinely done, like just for all?
Sir, so basically in Gujarat, it is done at Zydus Hospital in Ahmedabad. Otherwise, we generally refer to Mumbai. So Mumbai, there is Gleneagles. There is a lot of hospitals in Mumbai. Even Vadia Hospital is doing pediatric liver transplantations. In Pune, there is Ruby Hall. Delhi also, Medanta is there. So yeah, there are a lot of centers in India now available for liver transplantation. So of course, liver transplantation is very costly because the procedure itself is very costly. Pre-treatment is there, then post-treatment is there, and all of those. So Vadia Hospital has now started doing liver transplant since I think 3-4 years now. They are doing at a very low cost, and it helps a lot of people that are not affordable that ways. So.
Same is true for Apollo Indraprastha also at Delhi,
Yes, sir. Yes,
So they also manage
they
to,
also.
provide finances through some funding agencies.
Yes, sir. Yes, sir. That way, every hospital is providing some funding agencies because considering the cost effectiveness of liver transplant.
Right. So any other question? Dr. Hemant, you have some query?
Excellent presentation in such a short time. Congratulations, Jinal. My questions are two. Per operative cholangiogram is done open surgery or how?
Open,
And
open.
second question
Open.
is open. So patient will agree for only cholangiogram to open the abdomen of a
So
child?
generally we go ahead with POCs when we have like when we are 80 to 90% sure that it is biliary atresia. Only then. So that is how we explain the parents that once we do POCs and it comes out to be non-excretory, we will go ahead with Kasai then and there. So we counsel the patients like that. If it comes non-excretory, then of course it helps us with taking a liver biopsy. So definitely it will help us in giving a diagnosis. So yeah, parents do agree. It's a task
Se-
to counsel them otherwise because the child is growing well and all of that, but they do agree.
Second question is for case of pruritus. You said biliary diversion was done. What sort of biliary diversion?
Sir, it's a surgical procedure that again it's a operative procedure that some bile ducts that are been cut and then they divert into directly into the small intestine like that. So those kind of biliary diversions.
It is a kind of Kasai or enterostomy only.
No, not Kasai enterostomy. Just some bile ducts are cut.
Hepatico-enterostomy.
Yeah, yes.
Hmm. Try to avoid short forms, madam. POC, PFIC, BADC. Correct. Congratulations. Very good. Excellent presentation.
Thank you, sir.
Okay, so thank you, Dr. Jinal. It was wonderful to have you with us. And thank you all for joining. We will be now meeting, I have some few talks lined up. One is on 10th January by Dr. Nikita on interstitial lung disease, and 24th January by Dr. Palan. And 31st, we'll be having Dr. Ravi, cardiologist from USA. So we have few talks lined up for the coming months. So stay tuned to our group. Thank you. Thank you.